All right, everyone, we're going to get started. Can you hear me okay? Yeah? Okay, thank you for the, okay. My name's Sarah Marasco. Thank you for coming today, and thank you to all those who are joining remotely. I think we have a pretty good group on Blue Jeans, lots in Kalamazoo and elsewhere in the Bronson Health System, so that's kind of neat. We are very glad to have Dr. Paul Pfeiffer with us here today. Dr. Pfeiffer is an associate professor of psychiatry with the University of Michigan. He's also a researcher with the VA health system. And he is also the Susan Crumpacker Brown Research Professor of Depression. That was recently instated this week. I had to say it. So we're really lucky to have Paul here today. He's actually given this lecture for the Integrated Behavioral Health and Primary Care Certificate course with the University of Michigan School of Social Work. If you've attended that, could you raise your hand? We've got 4. Okay, great. So you may or may not have seen Dr. Pfeiffer lecture on this before. I do also want to announce that, excuse me, we have a sign-in outside for CEs. And when this gets started, I'm actually going to pass out the evaluation forms in order to keep these types of things free and available, and also to get your feedback. We'd really love to have you fill those out. And when you go and grab your certificate at the end, just place it face down next to the stack of certificates. And there's a handout out there as well. So this course is tailored mainly for behavioral health care managers in integrated care settings, given their high exposure with med monitoring and working on multidisciplinary teams. That said, it should also be very relevant for those of you who are working in integrated care settings, which I would imagine is a lot of you here, and those who are just generally working in behavioral health. So we're hopeful that you find this helpful today, and feel free to ask questions throughout. Great. Any questions so far?
Hi, everybody. Thanks, y'all, for being here. A couple quick disclaimer about the lecture course today. So this actually started, I used to teach a full course in the psychology department at EMU, and then I got asked to deliver this as a mini course for the School of Social Work. That was probably, I don't know, 8-10 years ago. And that was a 16-hour series of lectures. And then they asked me to boil it down to 1.5 hours. So basically, what I'm meaning to say here is that this is a lot of material. It was hard to kind of pick and choose what to go over today, and it's going to be pretty dense. So I will try to add in some discussion points. I'm happy to take questions in between, but if it feels a little bit dense, that's because I really wanted to make sure I covered the ground and got as much material out as possible. And then we can send out the slides later so you can look back and refer to those in the future. So that's just a disclaimer. Feel free to stop me at any point, and we might take a 5-minute break halfway through just so people can stretch and recharge and reset their brains for the second half. All right, so what I wanted to do today, again, and thanks, Sarah, for the introduction. I think the main thing is I am focusing this towards kind of a primary care, integrated care setting. So most of the focus will be on the antidepressant type class of medications and thinking around depression, anxiety. Those would kind of be the main focus, though I am going to brush on the other major classes of psychotropic medications as well, just so you have some familiarity with that. And then also focus just on common issues that come up when talking to patients about starting an antidepressant, sort of myths and FAQ type issues. And that's basically about it. All right, so just to start, so I'm going to start with this scenario. So, and maybe this has happened to some of you, but you're in your integrated care setting, and primary care doctor walks over a patient, says, introduces Mr. So-and-so, he's 85 years old. People can read the slide. He moved to a assisted care facility, not like himself anymore, doesn't want to do anything. The family thinks he's depressed. Should I start him on an antidepressant? How many people have had the experience of a primary care doctor asking them if they should start a patient on a medication? Is that okay? So I'm seeing lots of hands. Okay, so that's pretty common. So now that's typically not your role, and but they're asking community advice, and as part of a collaborative care program, you're probably going to talk to your psychiatrist, supervising psychiatrist about that. But this is a common scenario, so we're going to go with it. Oh, the other thing I wanted to do as part of the objective here is just to demystify psychopharmacology. For people that are brand new to talking about medications or working with medications, I think it can be, it's not normally part of social work training, so I think it can feel overwhelming or like, oh my gosh, there's this massive world of stuff I don't know. But it's actually, I think when we go through it today at the end, you'll say, okay, it's not quite as intimidating or scary as maybe I thought it was. All right, so back to the scenario. So the first thing when you have this question, should I start him on an antidepressant, should be, is there a reason to start an antidepressant? Do we have a condition, does this person have a condition for which an antidepressant is effective, right? So that's the first, should be probably the first question, I would think. So what are the conditions, and people can, I'm just gonna, this is a very easy question, but what are the, what conditions are antidepressants effective for? People want to yell some out? So that's, yeah, probably number one. What else?
Anxiety.
Right. So what anxiety, which anxiety disorders?
Generalized.
Generalized anxiety? OCD? Any other?
Panic disorder.
Panic disorder? And
Maybe with PTSD.
PTSD. So yeah, so those are the main, so I'd say those are the main ones. So especially in your primary care area. So you want to know, does this major depressive disorder is probably the, one of the most common, conditions. And then I'm putting in here, so people are familiar with the PHQ-9, measurement-based care. So usually you want to be at about 10 or higher to really think about an antidepressant. These aren't hard and fast rules. These are just kind of guidelines. So anxiety disorders, GAD, panic, social anxiety, OCD, you want your G87 to be above, about 10 or above. And then PTSD as well. In your PCL5, I don't know how people use that measure, but the cutoffs are a little less clear for that. But around 40 is kind of where I would think it's, you could maybe go a little bit lower, but that's about where you want to have your cutoff for that. So these are the major, indications. There's a few other minor ones. So people, and when we talk about indications, one thing that comes up is it off-label or is it FDA approved? And so these are all FDA approved, though not all antidepressants have the same FDA approvals. So like fluoxetine might have some that are different than sertraline, but generally we think of all of like the SSRIs as one big group. And then there's off-label use that for things like borderline personality disorder might be an example where someone might use an antidepressant even though there's really never been an FDA approval for it. But these are the main ones. Okay, and then is there a reason not to use an antidepressant? So is there a contraindication? So does anyone know of any cases where you would absolutely never use an antidepressant? Someone has depression, major depression, let's say, and then is there some reason why you'd say, nope, I am not starting an antidepressant for that person?
Long QT?
Okay. Could be, yeah. I think so. So long QT, for people who aren't familiar, is a syndrome of cardiac conduction where people have part of their cardiac conduction is prolonged. So that would put them at increased risk of an arrhythmia, and so that would be possible, and that particularly comes up with citalopram. For people have had familiar with it, citalopram is one particular SSRI. We'll get into in a minute. And that has a FDA warning against using it in long QTC. So, but I still think in cases where there are some antidepressants where we would do that, you'd have to use caution. Yes?
Manic episodes?
True. So if someone were in a manic episode, you would generally not start an antidepressant at that point in time. But so this is a bit of a trick question because there really are no very, very rare cases where you would say, not, like that's like impossible, we're not doing it. Because the SSRIs are generally safe. Now there are relative contraindications, cases where you'd say, okay, we need to really think about this, consider these other factors, and in our decision whether to start an antidepressant or not, we may need to select a different antidepressant or work on the dose or do something else. So the big one is bipolar disorder. So this is the one where you really don't want to miss a case where someone has had a history of bipolar disorder or a history of manic episodes in particular, and it's often helpful to know if there's a family history of bipolar disorder, because the problem here is that if you give someone with bipolar disorder an antidepressant and they are not on any mood stabilizer, then you could basically precipitate a manic episode. That person could flip into a manic episode, and then anything could happen from there. So it's really sort of critical, sort of be standard of care whenever you're starting antidepressant, before you start that antidepressant, to check, do you have any history of mania, family history of mania? Those are the really important things to check on. Now, does that mean you never use an antidepressant with bipolar disorder? No, because remember, antidepressants are also effective for anxiety. So if you have a bipolar patient that has panic disorder or PTSD or some other clear anxiety disorder, you can use the antidepressant type medications, but that person just needs to be on a mood stabilizer as well. So you need to have both. And there's large trial data to show that if someone's on a mood stabilizer, the antidepressant is unlikely to cause a manic episode. So they just have to be covered for that mood stabilization. Okay, so that's the big one. The other thing is just to make sure we're not missing something else psychiatrically that might be either more important or just to be aware of. So you don't want to just jump to, someone comes with depression, just jump to that and not think about, could there be something else going on? So that could be a substance use disorder, PTSD, any other number of things. Could be personality disorder. So you want to keep your differential open at first and kind of screen for some of these other things. And it's not that you can't start an antidepressant in those cases, because you can, but you just want to you don't want to just use an antidepressant, and maybe at this particular point in time with this person, if they have this kind of raging substance use problem, then you probably want your first leading recommendation is, well, let's address that. Maybe get you to a substance use treatment program, and let's worry about the SSRI later. So that would be another thing to think about. And then here's where you're probably going to be relying on, the next year you're going to be relying on your primary care doctor and your psychiatric consultant to look at the next two, because the next two are if there's a potential medical cause of depression, and then the fourth is whether there might be a medical condition or medications that would interact with that antidepressant. So on the next slide, I'm going to kind of go through that. So there's lots of medical causes of depression, and I listed them here. Basically, this is something that by the time you've seen the patient, generally they've already seen their primary care doctor, right? So that medical history has already been done. They essentially should have been assessed for most of these things. Or you can, if your primary care doctor doesn't think the patient has cancer, then you probably don't need to worry about that and try to work that up or rule that out yourself. Most of these things are generally going to be known. Now, a couple of these you might pick up, like obstructive sleep apnea would be like the big one, where that might have slipped through the primary care doctor, but then you're talking to them and they're talking about how tired they are, and and then you ask about snoring and all that stuff, and then you might pick that up pretty commonly. Most of the other things, though, you're going to pick up. Now, sometimes when I think of that gives me sort of a red light or a bulb goes off, is if people have more physical symptoms, have the more neurovegetative, let's say they're very weak or tired, but they're not sad or depressed. And if there's like a disconnect there, you feel like it's, I'm not getting the like the negative cognition stuff. I'm not getting the I think things are hopeless, or if it's all sort of physical, then you might think a bell might go off and just say, I wonder if there's something else going on here. This doesn't feel quite like depression to me. It feels more of a physical condition that's driving a lot of tiredness or fatigue. If you have other symptoms in there, like, I'm really lightheaded, well, that doesn't really sound like depression, right? So those are some things that might clue you in. Medications are also a big one. This is actually, people saw in the news, like in the past week or so, there was a big paper that came out that showed that something like 40% of people with depression are on a medication that causes depression or can contribute to depression. So, and I'll say this is not something that I have focused a ton on in my practice, sort of because these things are, a lot of these medications are so common. You just see, I mean, beta blockers and statins, pretty much everyone's on, it seems like there's on one of these medications. I guess the data shows that. So I think here, what I would clue in on is the timing. So when you started feeling depressed, was there a change in your medication? Did you start at that beta blocker like a couple weeks before or a week before? And so that's really, to me, what's going to help you tease this out, because the medication, these are so common, but if there's a temporal timing correlations, like I started this medication, then I started feeling depressed, then that's when I would sort of jump on this and think, okay, maybe it's that medication. Yeah.
So it's a medicine that, even though it was causing depression, was indicated, the doctor says, like, they still need to stay on it for whatever reason. Antidepressant to help to offset that side effect?
That's a really good question. I don't think we know that, like, definitively. I think it would be worth trying. Yeah, if they absolutely have to be on this medication, yes. And that would be, so I guess that would be a good example. So interferon is a treatment for hepatitis C. Now there's the newer one that is more effective, but the older treatment is this interferon ribavirin treatment, and that is classically like causes depression, like half the people that go through it. So in that case, we would do that, because that was the only option. Like if they're going to get, at that time, they're going to get their hepatitis C treated, they had to go through this. And so then we would jump in with an antidepressant, and then we would, kind of cross our fingers and hope it works. Yeah. Okay, and then the other thing when we think about starting an antidepressant is, are there other medical conditions where we need to just pay extra caution? Okay, and so the first is pregnancy, and I think I'm going to deal with that at the end. So I'm going to let's put a pin in that one. But the other one, seizures, bleeding, liver disease, kidney disease. These are situations where if you start an antidepressant that could, if someone has really severe seizure disorder, some antidepressant can like lower your seizure threshold, and so you want to think about it, like how important is starting an antidepressant, versus the risk of increasing the seizure. Should we talk to neurology and see about their seizure medications? Are we all good there? Bleeding, again, it's not generally something that most people are bleeding is going to cause a problem, but if you had a really severe bleeding disorder, SSRIs can interfere with platelet function and coagulation, so you want to make sure that you're involved. Someone has a condition. Liver and kidney disease, you might need to use lower doses, because the liver and your kidney are what gets the medication out of your body. So if those things are impaired, then you're going to probably need lower doses. So you have to adjust the dose there. And then for medications that interact with antidepressants, the main things that you want to look at are, there's basically two types of things that can happen. There's one is if you have too much serotonin, you can have a risk of what's called serotonin syndrome. So anything that increases serotonin in the brain, like the most common things are your migraine headache medications, like sumatriptan, so-called the triptans. So those can increase serotonin. Obviously, the older antidepressants that now get used a lot for migraines and nerve conditions, the TCAs. And then anything so that's one concern. You don't want to have too much serotonin going on. But then the other is that antidepressant medications can affect your metabolism of other medications. So if you're on a critical medication, like you have a stroke and you're on a blood thinner like Coumadin, or you have HIV and you are keeping your viral load down, or something, or a cancer treatment, that where your ability to process those other medications is critical to your health, then you need to consider what that antidepressant is going to do, because it could decrease or increase those levels. Same thing with birth control. That can be an issue too sometimes. So that's a situation where it's not you can't use an antidepressant, but you need to factor that in. And that's where you need to maybe consult with the other, like maybe it's consulting with the oncologist or the cardiologist or someone else and say, okay, what are we doing there? Or the anticoagulation nurse. Yeah.
That our specialty doctors don't necessarily have the intricate knowledge on that. Is there a place to look up? Is there, like, the interaction finders are going to be telling for things like that, or not?
They will. So yeah. So there are programs, websites out there where you can, and so like the Michigan Medicine has one. It's called Micromedics. You go in and you input the medications. Thank you for bringing that up. Where you can put in the medications. You just drop, get them from a list, put them in, and say go, and it will tell you all of the interactions, and it will test for that. And so that's what I will actually do most of the time. If there's any medication out there that's an unusual one, the person has an unusual medical condition, I will put those in and look and see what it says. And it will say something like moderate interaction, this could increase the levels of that, and so then you still want to say, probably have that conversation with that specialist and say, look, I really want to start this medication. I'm seeing here that it could cause this. Like, what do you think? And have a conversation about it. This isn't super common. So most people, like most of your medical conditions, like your cardiac conditions, your blood pressure and diabetes and cholesterol, those aren't really aren't generally problems. It's these kind of more specialized settings usually. Okay, so let's get back to Mr. M. So you review the medical record documentation, do your assessment. He's got PHQ of 18, depression started a month ago, no history of mania, substance use, or trauma. Medical history, he had a heart attack 10 years ago with a bypass surgery, has hypertension, high cholesterol, is treated with medications, beta blocker, ACE inhibitor, statin, and aspirin. All his lab work is normal. Would you consider starting an antidepressant? Would you consider starting an antidepressant at this point appropriate? Do you think it's appropriate at this point to do it? What might be further areas of focus in this patient prior to starting antidepressant treatment? What would people think at this point? Anything else you want to know? Yeah.
He's been on that for 10 years.
Yeah. So you might want to clarify that. Yeah. Right. Like, yeah. When did you start? Those medications. When were those started? Yeah. But. Yeah. Right. Yes. Yeah. Right. Maybe don't jump in right now. You just moved in. Maybe we could work on, kind of, maybe there's some tweaks or changes we can make to your living environment or how it's going there. And yeah, so there might be a behavioral, thing. Yeah. Okay. So that's good. The other thing that I thought about as just a general thing is just in terms of his age, so 85, the only thing I might just pay a little extra attention to is his cognitive status, and is there something going on there dementia-wise that can sometimes look like depression. So, but yes, in general, I think that the main thing is, it's a clear social stressor. You don't want to forget about that stuff, right? Okay. I have a little plug for collaborative care. I think you're all familiar with this. Just to reiterate for people that aren't super familiar with collaborative care, that in a situation like this, and when starting antidepressants in primary care, being part of a collaborative care team is going to, we know definitively that improves outcomes. So that means doing measurement-based care, supervision with a psychiatrist or prescriber, having a registry where you track people over time, and doing this self-management support as well. Those are the key ingredients. So plug for that. Okay. So now we're going to move into the biology, neurobiology stuff. So any questions so far?
actually was
Yes.
one.
Okay.
Somebody asked again, what was the name of the website?
Micromedics is what we use. Most health systems have paid, usually in my experience, have pay for one of these things for their doctors to use.
Okay.
Because kind of every doctor needs to be able to do that. So, but that's what we use, but there's probably free ones too.
Okay, thank you.
Okay, so before we get into this part, I just want to talk about why talk about this, because it gets into the nuts and bolts a little bit. So I think one thing is to explain how to, because clients, patients will often ask, well, what does this do? Like, how does this work, right? So so you want to be able to explain that, in sort of layperson's term. If you have a very advanced person in front of you who has a lot of knowledge, then you might want to be able to up that a notch to be able to talk a little bit more specifically. It helps knowing the how these medications work in the brain. Also helps understand the different side effects that can happen. It also helps you to organize your thinking around the medication. So rather than think of each medication separately, you can start to lump medications together as a class. And then it's easier to sort of think about them that way rather than separately. And then also the other thing that's really helpful is that when you see a new medication come onto the market, you can then sort of fit that within a category and say, okay, that's another one of those. So I expect it to act like all these others I've already learned about. You're not relearning every medication, for the first time. So I think those are the main things, why it's helpful. Is it really new? Yeah, so we get a lot of Me Too's out there, so you don't have to relearn everything. All right, so this is where the magic happens. Okay, so this is where basically all more or less psychopharmacologic medications, this is where they work in your brain, in your body. So this is what we're zoomed in on here is what we call the synapse, which is the connection between two brain cells or neurons. Neurons are kind of brain cells. So your brain has like billions of nerve cells and billions of connections. It's all connected. It's like the most complicated thing in the universe is this, right? All these kind of connections going on between these brain cells. And when you kind of zoom in, the way basically all thought, all behavior, memory, the way everything that we do, the way it happens is through a series of impulses going from one of your brain cells to another. If you think about like a supercomputer, right? You have all these ones and zeros that kind of like are flying around. This is sort of like kind of basically a 1 and a 0 in terms of like an activation of one neuron that then hits another neuron, and either it activates that next one or it doesn't. And the next one gets activated or it doesn't. And what you can have is multiple connections. You have multiple neurons that connect to another one, and they add up together. Whether they add up together to activate the next one, that's how the information in your brain is flowing around, and that's how everything we do is happening. Okay, so it's amazingly complicated. But so what happens actually is it's actually an electrochemical reaction. So you have actually like an electrical gradient that goes down the sort of the now I'm thinking of the name, the outside of the neuron, the membrane. There you go. So, and then what happens is when it gets to the end, the electrical chemical gradient gets to the end of the membrane here, which is the top part, then in order for it to actually send a message to the next neuron, it doesn't do that with this electrical part. It actually sends a chemical, and that's called a neurotransmitter. So the neurotransmitter is the chemical that gets released and crosses the gap, which is the synapse, to the next neuron, and that's how that message gets sent from one to the other. And again, multiple messages can be being sent from multiple neurons to the next one, and there's different types of messages. So that chemical, the neurotransmitter, crosses the synapse, and then it binds to a receptor at the next neuron. And then when it binds there, it can sort of create a little bit of electrical chemical thing that happens there, And if enough electrical chemical stuff happens, then it triggers another activation and the next neuron fires. And then so on and so on. So so pretty much all of psychopharmacology is working in this area of with these neurotransmitters. And there are several things that can happen in different ways in which our medications work. So, so there's the kind of forming of the vesicles and then the little packets that then get released, right? And then they get put into the synapse and then they get taken back up into where they came from. So that it can be blocked. So you can have things that increase that release, decrease that release, that decrease the coming back up. So the SSRIs, selective serotonin reuptake inhibitors, they block that reuptake. So if you see people, I don't know if my mouse works. So this is here. So this is where the SSRIs work. They block this from happening. So you have serotonin released. There's a bunch of serotonin here. It's binding to these serotonin receptors. It's activating this neuron, and then it's wants to go back up into this cell, but the SSRI sits there and says no. And so there's more serotonin floating around, okay, in this little teeny synapse. So that can happen. You can have medications that just mimic the serotonin or not. Well, there's theoretically, and could bind to these receptors. They could modulate these receptors so that they're more sensitive or less sensitive. They could block these receptors so that the serotonin tries to activate these and it can't because there's something blocking it. There's other enzymes that chew these up and eliminate them from here and kind of clean up. And then there's medications that will block those enzymes so that there's more that way. That's how the MAOIs, like the really old school antidepressants work. They keep these from getting chewed up. And so there's more of it in there. Not sure if there's any questions on that. So that's that. So we're going to get into more of this, but in terms of the basics of like how this is all working, any questions there? Okay. Have people all know this already? Oh, okay. Okay. All right. So I just focused on serotonin. Now but there are multiple neurotransmitters, and they each do different things in the brain. They each also have their own associated side effects. So I kind of listed the major ones here. So serotonin, is related to mood, anxiety, sleep, anger, aggression. Side effects: sexual functioning, gastrointestinal functioning. There's more. I'm just kind of highlighting the big ones. Norepinephrine, mood and anxiety. Side effects: heart rate, blood pressure, fight or flight. So these all work on different things. So dopamine, listed them there. Histamine and melatonin work on sleep. GABA is basically a broad spectrum inhibitory neurotransmitter, so it just kind of reduces the activity sort of globally is kind of a way to think about it. It kind of decreases the likelihood that the next neuron will fire when it binds. And glutamate is kind of the opposite. It kind of is kind of an excitatory, kind of turns up the dial in the likelihood of that next neuron firing. And then acetylcholine has a lot of effects more on your not your central nervous system, but your kind of peripheral nervous system. So your heart rate, your bladder, gastrointestinal system, and so what this often comes up in what we call the anticholinergic side effects. So, and this is most common in the older antidepressants, like the tricyclic antidepressants. Sometimes we see it with Paxil. It tends to have a little bit more of this anticholinergic side effects. And so that can be things, typically people get like dry mouth, constipation, problems urinating. And so if you ever hear about that, your primary care doctor or your psychiatrist says anticholinergic side effects, this is what they're talking about. Okay, so And then the other sort of thing that makes this all complicated is that you have so I talked about the neurotransmitters and the synapse and just really focused in on, let's say, the serotonin synapse. But then the way these neurotransmitter systems work is that they actually go throughout the brain. And when you take a medication, that medication kind of goes everywhere in your brain, right? It's not like it just goes to your frontal lobe, right, or your occipital lobe. It goes everywhere. And so it hits all of the pathways, or can hit kind of all of the pathways that are relevant. So in one of the this is the dopamine pathway, and so this is just a good example because we see when we use, so we'll get this in a bit, but antipsychotics block dopamine. That's kind of their primary, that's what makes them sort of unique in how we think they work against psychosis. So when you block dopamine, you block it in like the frontal cortex, and that might deal with psychosis. It could, affect, but that's where your executive planning and motivation work. You can block that part there that goes to the pituitary, so you could actually stimulate lactation because that's normally stopping lactation in women. So that blocking that can start that. If you get into that nigrostriatal pathway, that's actually the pathway that's relevant in Parkinson's disease. And so you can actually cause like a Parkinson's-like syndrome with an antipsychotic because it's hitting that pathway. So the reason why the take-home message is the reason why we see these medications have different effects, some positive, some negative, is because they're messy and they just go everywhere and they hit all these different pathways. And so it'd be in an ideal world if we could figure out ones that don't go everywhere, then that would be great. But we haven't figured that out yet. And I'm not going to get into the other thing is that remember I talked about like serotonin receptors. There's also different receptor subtypes. So there's like your 2A, 5-HT2A or 1A, and that gets even things more complicated. Okay, so any questions on the neuroanatomy, neurophysiology, neurotransmitter action stuff? Good. All right. Okay. Now we're going to get into a bit more of the didactic kind of stuff on just kind of going through the major medication classes and starting with the antidepressants. So I've already touched on these a little bit. So these are old school antidepressants, MAOIs, TCAs. Anyone have any patients on an MAOI? In the room, I'm not seeing any hands. I don't have any personally. Okay. TCAs? So these are your nortriptylines, amitriptylines. So these are most commonly used now in my experience, by non-psychiatrists. So they're usually used by primary care doctors in neurology for things like chronic migraine headaches, sometimes for like diabetic neuropathy, neuropathic pain. Those would probably be the most common ones you see. So sometimes you'll see a primary care doctor use it for sleep, because they're sedating, so that happens. Wouldn't be my first choice, but so these are so you see them a lot. So you need to be aware of that because what I mentioned earlier is with the whole serotonin, too much serotonin. So if they're already on a TCA and then you're starting another antidepressant, or maybe, and then they're also on, let's say, a triptan for their migraine headaches, then you start to think about, okay, maybe we need to, think about how much serotonin is going on here and the risk of serotonin syndrome. So you need to be aware of this. The other thing that, so why do we not use these anymore? We don't use them anymore for a couple main reasons. One is that they are much more dangerous than overdose. They can cause a cardiac arrhythmia and people can die. So that's one big thing. So when you're starting someone on something for depression, a lot of times there's suicide's a risk factor, concern about that. So it's a big concern. So that's one thing. And then the other is that they have a lot of those anticholinergic side effects that I just talked about. So dry mouth, constipation, that kind of stuff. So we don't tend to use these. And there's some evidence that people will be less adherent to these than SSRIs because of the side effects. So there's actually some evidence to suggest that they're really not a good first-line choice. Now we're into the modern antidepressants. So, these really, the SSRIs kind of came around, in the early 90s. And basically, this is what, in a lot of ways, I think of it as kind of paved the way for primary care doctors to start doing a lot more antidepressant treatment, antidepressant prescribing, because these are a lot safer, they're a lot more better tolerated, and so that we've seen sort of an explosion of antidepressant prescribing kind of since then. So we're going to talk about those. The SNRIs are closely related, and then there's a couple sort of more unique medications, bupropion, mirtazapine, and then there's a couple other newer ones that I don't really see a whole lot, but we'll just touch on. Okay, so here are the big ones, the SSRIs. So we have your Prozac, Zoloft, Paxil. So the way I'm doing it is the generic names going first, and then the trade name, the brand names going second. These are all generic at this point. So most of the time you're just going to see the generic name. So these are the big ones, so these are indicated for major depressive disorder, the major anxiety disorders, kind of what we've already touched upon. And then the main thing is, you want to talk to your patients about, other than, how to take it and that stuff, which we'll get to, is the side effects. And so these are the ones that are the more common side effects, and what I warn people about. So my standard spiel when I'm talking to someone about starting an SSRI is I say the most common side effects are gastrointestinal, like nausea, diarrhea, constipation. In rare case, would you have vomiting? It'd be rare. I usually probably don't even mention that. And I say usually those go away within a few days. If you have them, they're usually not severe, no bad, they're going away. Then I say there's also, and I just go right in, there's sexual side effects that could be, sexual performance, interest in sex. And then I always try to say, but if it happens, it's not permanent. So I don't know if people worry about that, but I just always like to tell, because it sounds bad. Like I'm gonna, I could just imagine somebody like, oh my God, I'd never touch that, because you don't want to have like a permanent. So it's not permanent. If that happens, we just stop it and you can try something else. I don't usually actually warn people about the early activation, but although it is a thing that people can feel more restless. If someone is super anxious, like just really restless, super anxious, then I might bring it up. Like you might feel a little bit more anxious in a few days. Don't worry, that it will go away. This is really good for anxiety, but you might have a little bit at the beginning. So not for everybody, but if the film is really anxious about it, I will warn them about that. And then I usually will say something like, and then there's just a lot of things we can't predict. Some people have changes in their energy. Some people feel like just less emotional overall. And it could make your sleep better. It could make your sleep worse. It's a little bit unpredictable. So those are the main things. If someone is concerned about weight gain, then I will tell them that some people do gain weight on these, although they're not terrible offenders. There's a lot worse medications in psychiatry that we use that cause weight gain. Maybe it's kind of relative, but there's about 1% per year. So it's like like a pound or two a year on average. So some people don't gain weight, some people gain more, less, but that's kind of the average. Yes.
So what the
Yeah.
if they're having a sexual side effect?
So that's a really good question. Yes.
the question
Yes.
for the-
Oh, okay. So the question is, if someone has a sexual side effect on one SSRI, would I switch to another SSRI or switch to a different class? And it's a good question, and I would say not just with sexual side effects, but with any side effect, you kind of apply that same question. And so my general thing is although there's a specific, that actually is a little bit different, because there are, I'm going to estimate, so bupropion, right, has pretty much zero sexual side effects. So in that case, I would really think, okay, in that specific case, I would think maybe we should consider bupropion if it seems appropriate. If it really seems that an SSRI would be better, then I would go with an SSRI. And for most side effects, just because they have it with one medication does not mean they will have it with another. So I very frequently see the case that they have like a really bad GI with one, and then you do another one, and that's not there. So that's what my typical practice is to say, okay, I'm sorry you had that with that one. Let's try another one. There's often little correlation between whether you'll have the same side effects with this next medication. That's been my experience. Yes.
Sorry. So if that's if you have several SSRIs, that are more common, like is it more common to get sexual side effects?
I tend to think of them as across the board. Yeah, so the question is, if someone has had a particular side effect with one medication, could you then pick another one based on that to try to find a medication that has the least likelihood, I'm sure paraphrasing, of that side effect? So that maybe you want to pick sertraline instead of fluoxetine because sertraline has somewhat less likelihood of that particular side effect than that. So you can do that. And if a specific case of a patient where this is like really a critical issue, I might go to the trouble. So what you'd have to do though is, I don't remember in my head. I don't have the percentage likelihood of each side effect for each SSRI. Like I just can't store that in my brain. So I would have to go into the actual prescribing information that each medication has, which is you can look up the someone have like there's like these physician desk reference, like big tomes, but there's the prescribing information, which is the package insert is the other way people call it, that has all of that information for each medication. So if you go to that's what I would basically have to go to. You would see what the manufacturer reports out as how often they had that side effect in the medication versus the placebo in their controlled trial, and what happened a certain percentage time. So if you go through all of that, you could shave off a few percentages here or there and say, okay, I'm going to do this one because in these trials. But I don't typically do that. So because I think that it's unpredictable, like in a lot of ways. Like people are just going to have, there's more variance within that individual, like how they're experiencing this medication versus that. You're to look at population averages and say, for you, I'm going to try to thread the needle here. Like it's just, so I have done that before, but it's not typically what I do. Yes, yes. Usually they're kind of the same. So it usually doesn't get to that point, but you can do that. And honestly, I guess to be fully honest, I'm not sure how much I believe that just because they reported these 2 trials here and they found that, their sexual side effect incidence was 15%, and then this other medication reported their 2 trials here and their sexual side effect rate was 10%. I would want to see like 100 trials of each, and then maybe I'd believe it. But like they're just picking 2 things, and so I don't put a lot of stock into it, honestly. Okay. So here's the talk on serotonin syndrome. So this is a serious problem when it occurs. It's potentially life-threatening. It's relatively rare, although it's a bit of a spectrum. So some people can have the early signs of it and not have kind of the full syndrome. But basically, what happens if someone, so it would probably be kind of most common if someone overdosed on their SSRI or serotonin agents. But if you get into really high doses, multiple medications, that's also usually when it would happen. Then you can have the syndrome. And basically, what it is, people have the classic sort of symptoms. They have fever is one. They have muscle rigidity. So that like they have a hard time moving their muscles are stiff or rigid. And then the other thing is they'll have severe gastrointestinal, like diarrhea, severe kind of symptoms there. So it's sort of this cluster. They may be agitated or even possibly confused. So if this ever were to happen, so they should just go to the emergency room, like just go and get addressed and make sure that that is controlled. So I put here the other medications that you want to think about in terms of that could in combination lead to this syndrome. But I think I've already mentioned a couple times now, it's the most common ones that I run into are the migraine headache and the triptans. And there it's always a little bit tough because, you don't want to necessarily say make someone choose between depression and migraine headache, and so what I'll usually do is, personally, I'll just use low doses of the antidepressant as low as possible. I'll warn them about this syndrome, and I'll say, definitely do not take more than your recommended dose of your migraine medication. So stay within recommended dose ranges. Do not take more than you're being prescribed, and be aware of these symptoms in case anything like this happens. Okay. So here's this question about like the differences between the different SSRIs. So so there's a few differences. There's more in common than there is really different between them. Okay. And there mainly are, so like people are aware that they each use different doses. That doesn't mean one's more powerful or effective than the other. It's just they just use different milligram strengths. Here I put on citalopram and sertraline have fewer interactions with other medications. So that's true. So they can be good for people that are on lots of other medications. So they're more cleaner, I guess, if you want to put it that way, than like fluoxetine. Fluoxetine has a longer half-life. So if people miss a dose, then it's less pronounced in fluoxetine than other medications. Although, you want people to take them, but if you did feel like someone was really just unlikely to take it every day, then that would be a better option for them. The citalopram, I don't think I put on the slide, but just go back up that for a second. If you remember, that was the one that has the FDA warning for the QTC prolongation, so that has dose restrictions because of that. So if someone if they're older as well, then they can only go up to 20 milligrams. So particularly for older patients, I don't tend to start citalopram anymore because you're very restricted in the dose. And then paroxetine is just the one I see prescribed the least. I personally don't prescribe it hardly ever myself. I don't know if I even have in the past 10 years. Just because it has, when I was going through my training, I don't even have much experience prescribing it because I was just told it's not a really good one. So it has anticholinergic side effects and worse discontinuation syndrome. So that's kind of what. So they're more similar than different. Do people want? So I got this sign that we're halfway through, but let me keep plugging along and then we'll take a break. Okay. So those SSRIs. Any questions before I go? Any pause for questions? Okay, your SNRIs. So you got your venlafaxine, desvenlafaxine, which is just basically the same, duloxetine, and this new one, which I haven't seen a lot of. And so basically these work very similar. I tend to think very similar to the SSRIs. There's really just like one or two key differences. Because they work on the norepinephrine system as well as serotonin, they also are, there's basically two things. They can be better for neuropathic pain, so again, like migraines, diabetic neuropathy, but then the disadvantage is they could have greater hypertensive effects. So if someone has really bad hypertension, that's a real struggle, a lot of cardiac risk factors, then that might be a consideration to not use an SNRI. Now, bupropion is totally its unique medication. So it does not, it's not very serotonergic. It actually works more on norepinephrine and dopamine. So then it almost makes you wonder, like, why? How does it work? You know, why? I thought serotonin was critical to depression. This doesn't make sense, and I don't have a good answer for you. That's just the truth. I mean, I don't have a good answer for you. So we know the brain is super complicated. You know, you affect norepinephrine here and dopamine there, and that eventually affects serotonin somewhere else, or vice versa. You know, we just don't know the exact nature of it. The key, difference, the key things about bupropion. So advantages: less weight gain or sexual dysfunction, or sexual side effects. Disadvantage: not effective for anxiety disorders. So this is really big, and this is like the often the sort of decision point in starting an antidepressant is, do you want to use an SNRI, or do you want to start bupropion? You know, because of this trade-off. Now, what I will say is, because they're not effective for anxiety disorders, that doesn't mean that if someone has, because depression and anxiety are so commonly comorbid, right? Like when you look at your PHQ and your GAD, they're very correlated, almost always kind of go hand in hand. That doesn't mean if someone has, a PHQ of, 20 and a GAD of 10 or 12, that you can't use bupropion just because they also have anxiety. What I'm talking about here is if they have a separate anxiety disorder, like they have panic disorder, they have PTSD, they have some sort of, social phobia, OCD. If they just have depression and anxiety, and it's all depression and anxiety kind of go together, it's just an anxious depression, that's fine. You can use bupropion. Now, that's my message, and there's some trial evidence to support that. But the different providers and prescribers will think differently. And that's fine. But some will just totally shy away from bupropion if the person has like any anxiety, which is a lot of people. So I don't, sometimes if someone is really super anxious, and it's just like, you can tell, right? Some people have more anxiety, like they exude more anxiety than others. And if they're exuding a lot of anxiety, that might shy me away from bupropion as well. But you just kind of factor that in. It can. Yeah. Yes. Oh, does it ever increase anxiety? Yes, it can.
I've heard that it can be helpful for folks who have really low energy and are really sluggish. Is that true, or is that?
Yes. So, okay, yeah, that's a good question. I didn't put that on here. So the way to think about bupropion in a way is it actually chemically works similar to a stimulant. So stimulants like your Adderalls and Ritalins, they also increase norepinephrine and dopamine. So, but I think of it as like, I don't want you to think of it's like an Adderall or in that same way, but in a way it is, but over like a much longer time course, because it works like antidepressants that they take weeks to work. It doesn't work right away. It's not like you take a Adderall and you're boom, I'm feeling it, right? But it does have a similar sort of neurochemical properties. So I tend to think of that way in the sense that this will be more energizing, kind of more motivating, and also you shouldn't take it late in the day because it can interfere with your sleep. So it's activating. And right, the kind of lower weight, like you don't have as much weight gain. That's all goes along with like kind of like a stimulant. All right, mirtazapine is, and I think of kind of like the opposite of bupropion. So I kind of think of them as like kind of opposites, because whereas the bupropion is like the stimulating, energizing, will keep you up at night if you take it too late. Mirtazapine is like the opposite. It's sedating. It slows people down. It makes them gain weight. Makes their appetite increase. It helps them go to sleep. So in some ways, that's kind of how I think about them. Now they are not as the issue with the anxiety disorders with mirtazapine. That's kind of the big thing, is that they're really not far as when I last checked. Not proven to be effective for anxiety disorders, but you know, in a pinch, you could, if it was depression plus anxiety, I wouldn't generally use it for anxiety alone, but depression plus anxiety, I think that's fine. But yeah, for the clear-cut anxiety disorders, you want to stick with the SSRI, SNRIs. But this typically will not make anxiety worse. All right, so this is the new ones, which I don't really see. Have people seen examining providers that have using these? So I work in the VA, so we don't get the new stuff. We just have the old stuff. So I don't see this a lot, or really hardly at all. So these have this sort of unique action that they are kind of like SSRIs, but they also partially activate the receptors, the serotonin receptors, the kind of postsynaptic receptors. So, and I can't say to why that's better or definitively what advantage that conveys, but it seems like if you've tried the other ones and it hasn't worked, then these would be reasonable to try. They're going to probably be more expensive. Yeah. Okay. So they're not. So Carl is saying they're not in Medicaid formularies. So you have to check with your insurance and that kind of stuff. Trazodone, I'll briefly mention, it's really used in low doses for sleep, so it's really not used as an antidepressant. Technically, most people don't. You have to get into the much higher doses, like 300 to 500 milligrams, for it to have an antidepressant effect. So most people just use it in low doses for sleep. It has a rare side effect of causing the erection that won't go away, like you see in the Viagra commercials. Also warn people it could cause kind of like a little bit of a hangover the next morning. I warn people about that. Okay, I'm going to go through these and then we'll take a break. So here's the quiz. So you have a 38-year-old woman with depression and PTSD. Here are your options. What would people pick? Sertraline? Right. What about venlafaxine? What if they've already tried sertraline and another SSRI? Would venlafaxine be okay? Yes. Yes. Right. So you would not want to pick bupropion because it's not good for PTSD. Right. All right. 55-year-old woman with depression, anxiety, insomnia, and weight loss. What would be mirtazapine? Right? Because that helps with the weight loss and the insomnia. Got some anxiety. What about fluoxetine? Would that be okay? Yeah. What about bupropion? Right. So yeah. So exactly. You're getting it. So 25, depression with no major anxiety disorder, smokes cigarettes, anorexic, and seizure history. What would you? So I kind of tricky one, right? Okay, good. Yeah, so I'm starting to ramp it up a little bit. So what was? So I didn't go into this before. So I'm glad you guys caught that. So anorexic and seizure. So bupropion is associated with seizure. The case that's known to actually cause seizures in people with anorexia. So bupropion would be fairly contraindicated in this case. But the smoke cigarettes was the red herring because bupropion is good for smoking cessation. So that's the tricky one there. So the other ones would be fine, I think. And then let's see. For with depression, chronic headaches, fibromyalgia, excessive sleep, and weight gain. Duloxetine, right. So the SNRIs, there's the fibromyalgia, headaches, that kind of things, more in the duloxetine SNRI because it has that kind of, the norepinephrine gives you that, or neuropathic pain, headache kind of stuff. So yeah, fluoxetine would also be good. Maybe bupropion not so good because of the headaches. But the other parts would, the excessive sleep, weight gain, that would be good for. So you can kind of see how you get these pictures and you have to this is where the art comes in of doing this. It's sort of like you have this sometimes this, this medication would be good for this, but then they have this other thing where it wouldn't be good for that. And so that's where your psychiatrist should be coming into play and kind of helping you think through these things and be the one that says, okay, taking this all together, I would do this, and this is where the extra 8 years of training comes in. All right. So you have what if the initial treatment fails, which happens quite often? You have these next steps. You can increase the dose. So if you start at a low dose, then you can go up on the dose. Whether the mileage you get out of that is not a lot, to be honest. A lot of the evidence coming out now shows that these dose escalations don't really tend to get you a whole lot. So I usually tend to think about that as if they're showing some benefit early on, like in the first 4 weeks or so, then okay, let's go up. But if it's like 0, they've gotten nothing, and it's been 4 to 6 weeks, it's unlikely the dose increase is going to kind of get us there. So that's one option. The next would be if you've already added a very good high dose, then you could add a second medication. So that would be and here you can do these combinations. So you can add, you start with your SSRI, your SNRI. I consider those to be the same for this case. So you don't want to add SSRI plus SNRI, but you can, if you consider SSRIs and SNRIs to be one supergroup, then you can add to that bupropion or mirtazapine, because those work very differently. Those would be common strategies there, and so those are fine to work together. And you could do bupropion and mirtazapine itself. That's fine. You can use those two together, although it's a little bit like you're kind of, both ends of the stimulating, sedating thing. But it's possible. And then the other thing would be just to switch to another antidepressant. So if someone is not responding at all to that first medication and it's been 4 to 6 weeks, then I would typically say, let's just switch to another SSRI. Or you could switch to the bupropion or mirtazapine or whatever. There was a very large trial, people heard of it, called STAR-D trial that happened 10-ish years ago, where they tested all of this out. And they said, okay, if I fail, everyone started on citalopram. And then they said, okay, you fail citalopram, then we're going to either switch you to sertraline or switch you to bupropion, or we're going to add bupropion, or we're going to do this, do that. They really found nothing. It really didn't matter, basically, the upshot was. So you can just do any of these things. And they're all equally effective. They're all equally effective. There was no superior strategy that came out and said, when you fail this, you should do it. They did not include antipsychotics in this trial. So adding the antipsychotic was not included in that trial. There's been later a trial that looked at adding an antipsychotic versus adding bupropion. They're pretty similar. The antipsychotic actually did a little bit better, but it has more side effects. So some side effects. So that's the only kind of caveat there. So the third option there is you could add one of these antipsychotics like Abilify or Seroquel. Would be the main ones. Okay. And then the big thing is, after 2 failures, scrutinize the diagnosis, consider intensifying treatment. That means, like, if you're in a collaborative care model, if you already failed a couple, 2, 3, 4, then you might think about maybe they should have more, like, go to a specialty care setting and get more intensive treatment there.
How now they're saying that ECT.
I did not. So the question is about ECT and where this falls in the spectrum of when to start ECT.
You mentioned maybe
Yeah.
after 2 trials.
So there was a study that came out that looked at the cost effectiveness. I think this is what you're referring to. There's a cost effectiveness study which showed that ECT is cost effective after 2 antidepressant treatment failures. So there's a big difference in my mind between cost effectiveness and when I would recommend something to happen for a patient and what an insurance would likely pay for. I mean, they might not be convinced that this is the next good step, and I probably I might agree with them. So It's extremely rare, in my experience, for someone to get ECT who is basically appropriate for outpatient care, unless So it's usually someone whose depression is so severe that they get hospitalized because they're unable to function, or they're severely suicidal or psychotic, or they have something that's fairly extreme. That's usually what triggers ECT. So if someone has failed 2 antidepressant medications, you're really in the position of like, well, maybe I start an antipsychotic, or maybe I start bupropion, or maybe I switch to this and add that, versus ECT. Those are like your 2 options. I think this is a good question. I don't think that, I don't know. I don't know if we know the answer. I mean, it may be ECT. It probably is more effective. Like if that person was like, I don't care. I want to just do the most effective thing. Like I just don't want to be depressed anymore. Whatever it takes. I have the resources. Just do the most effective thing. Then yeah, it might like if they're losing their job or something's going downhill and they just need to get on track immediately. Then yeah, ECT would be the thing to do. But ECT has all its other drawbacks too, right? I mean, so it's expensive, but it also has cognitive side effects. So people can have memory impairments, lose memories. So that's the other thing. There's going to be more serious side effects potentially with ECT. So I think there is a movement to like get ECT earlier in the protocol, but where it should be, I think is a little bit unclear. So what I'm going to do now is run through the other major psychotropic medication classes so that you're familiar with these as well. So benzodiazepines, also commonly used in primary care. I tend to see actually a lot more of primary care doctors starting these than I start. But and for whatever reason, primary care doctors really like Xanax, where I prefer Ativan or Klonopin. The main thing there is that is half-life. That's kind of the big difference. So Xanax has like a shorter half-life. It's quicker acting. So it's more rewarding, honestly, and so people like it. But that's a concern for being too rewarding and developing dependency, whether it be sort of behavioral dependency, they just have to have their Ativan in case something happens, or it's actually like a chemical dependency. I mean, those are kind of different things. The chemical dependency addiction kind of piece, it develops over time with sort of repeated daily use. The exact time, there's not really a hard science on that, but you're kind of thinking like months, like more than a month, couple months, 2, 3, 4 months, then people can start to have a physical dependence. And then the issue is when they try to come off the benzodiazepine, they will have worsening anxiety. And in very severe cases, if someone went cold turkey, they're taking high dose benzodiazepines daily for months to years or whatever, and they cut off cold turkey, it's possible they could have a seizure, similar to like if a person with severe alcohol problems could have a seizure. It's possible you could have that with coming right off benzodiazepine. So those are so those are some concerns there. The other things with the benzodiazepines I have on the slide is kind of just sedation, driving. They work synergistically with alcohol. So if someone's using alcohol and taking a benzo, that's a big problem. I'm going to talk about opiates as well. That's also a concern. Mixing with opiates is a big concern, particularly these days with the epidemic. They're not effective for depression or PTSD. So although it seems like because they're anti-anxiety, these medications work right away. People like them because that's the other reason they like them, because they work right away. But they're not effective for PTSD. The trial data shows it's not effective for that in the long run, and because of the risk of the dependence issue, that's why we don't recommend them for PTSD. All right. Any questions on benzodiazepines? Yes.
Can you just speak quickly to advice for patients that are no longer able to find supplies of benzos? I mean, that have, a risk factor for addiction, of course, but
Can't find supplies? You mean like
yeah, doctors are not willing
no
to
one, they really want one and no doctor will prescribe it to them?
I'm not sure well, because they're going to
Yeah.
tell us if this is the only thing that's ever worked for me, and now
Right.
I can't find anyone to prescribe it.
Yes.
What should I do?
Yes. Well, so I mean, I basically the way I address that is by saying, well, like I have other options, and then we're gonna have to try those. So my general feeling is on this is that if they really have literally tried everything else, and this is the only thing that will work for them, then I'm not entirely opposed to it. And in that case, it could be fine. But I would want to try the other things as well. And it depends whether they have a substance use history or propensity for substance use problems. If they do, then generally I would not prescribe that. I would have that be referred to especially like a substance use clinic, and I would leave that up to a substance use specialist, a psychiatrist who's trained in addiction, to manage that situation, because that there's going to be special monitoring that goes into that, and setting of limits and like other treatment that could be offered to them. So that's the case if someone has an addiction history. They don't have any addiction history, and they've tried everything else, then I think sometimes the benzodiazepine can be used and appropriate. In general, I use benzodiazepines for only kind of two cases. One is if someone has a very severe acute stressor, like they just found out, their spouse just told them yesterday they're leaving, right? Or major death in the family, like something where they are completely distraught, they can't sleep, they can't function. You don't have weeks to start an antidepressant, right? You need to get this person functioning, like getting through the day, right? So then a benzodiazepine can be helpful, and I think it's totally appropriate. And but it should be very clearly upfront saying this is short term, like we're talking a month, and then we're done with these. So we're getting you together, and then that's it, And then we also might want to be starting that SSRI, depending, if they had no depression, boom, this thing happened. Now you don't need to necessarily start an SSRI at that point, because they could start coping better and may not need it. So that's case one for the benzodiazepine. Case two is the case where they've basically tried several SSRIs, they've tried all these other things, nothing has worked, and they have really severe anxiety, then benzodiazepine. I think that should generally be done through a psychiatrist situation where they're in kind of a specialty level of care. But depending on your setting, you could do that there. So that's usually kind of how I think about benzodiazepines. Now, so yeah, you do find the people that have been on them, it's worked for them their whole life, right? They love it, and then they meet the primary care doctor, and the primary care doctor says, nope, I'm not doing benzodiazepines, you're coming off, right? And then they send them to you, maybe, right? So that is hard, and and so that's what you're talking about, I think, right? So I think in that situation, you just have to say, look, this is what Dr. So-and-so has decided. I'm here to help you manage getting off that benzodiazepine by behavioral strategies. Maybe we can work with the psychiatrist, find other medication options. But if you're not willing to consider any of that, then you need to find care somewhere else. I mean, I think that's just where you're at. I've been surprised when in some cases, it obviously doesn't work for everyone, but but I at least need to give it a shot by telling people the reason why this is happening, because some people will not really understand it because it was never explained to them. So I will make it clear the reason why we don't want to prescribe this benzodiazepine is because well, first of all, it has a risk of abuse, independence, and addiction. And some people are like, oh, I didn't know that. Oh, yeah, take me off. Some people, you say, when you get older, particularly, you have risk of confusion, dementia, cognitive impairment. fall risks. And then I just had a guy this week who was on opiates, and I said, there increases your risk of opiate problems related to opiates, opiate overdose issues, and he was like, okay, I don't throw it away. So you need to at least explain those things. Some people that are wedded to it, obviously that's not going to matter. Not typically. It's not like opiates in that way, where you do tend to see this constant escalating dose. So no, a lot of times people will find the dose that works for them, and they can stay stable on that. The Z drugs are, because they all have Z in the name, are these sleep medications. They're very similar to benzodiazepines. So they kind of are marketed as less concerning. Less addictive, but they're really very similar, and so you can almost consider them like benzodiazepines in a lot of cases. But they're marketed for sleep, and they have basically essentially the same risks and side effects. So you kind of just think of them that way. For sleep, I don't personally. Because of this, I don't tend to prescribe much of any of these. I would use the, I think I get to that maybe next slide. Hold on, let me skip to that. There, yeah. So for sleep instead, I would tend to use, so you can use it down towards the bottom, the antidepressants like trazodone we talked about, mirtazapine, particularly if they also have depression already, then you can use an antidepressant. Melatonin is obviously very, it's natural, your body produces it anyway, so that's fine too. But so, like I said, my first recommendation for sleep is CBT for insomnia. I mean, that's number one. But if they've tried that hasn't worked, or there's for some reason there's no way they can do it, then I might consider some of these medications. But generally medications aren't great for sleep. They get you maybe an extra half an hour of sleep. They often work initially, but then stop working. So I tend to think medications are a lot of times overrated for sleep. Yes? Yeah, so question is, someone has patients on Belsomra and asking my opinion on it. So I have not, because again, this is kind of a newer one, the VA, it's on the VA's formulary. It's probably expensive. But so what I can say is that the last conference I was at, like a CME conference, the sleep expert who was speaking really was advocating for this as being like far and above better than the other sleep medications. Just by the way it works, its mechanism, it's different. It works through this orexin, which is related to like the narcolepsy, kind of pathway. So it's a very sleep-oriented kind of mechanism. So he was particularly a fan of this. What have your patient experiences been? Oh, really? Okay. Oh. Okay, so I'm hearing bad things over here. Sleepwalking, night terrors, sleep behaviors. So there you go. So yeah, it's newer. I haven't really. Yeah, I would use it with caution. Any of these new medications like that. I did have a good experience once with Rosarum. That's a melatonin agonist. You would think in a lot of ways melatonin would be cheaper and easier, but I did have again, it's anecdotal, one good experience with that. So I'm not totally opposed to Ambien. Like if you tried a few things and you can do. I don't want to be like a hard line about it, but I would usually try a benzo like medicate a couple of those first, CBTI first, maybe you'll work your way to the Ambien. All right. So here's my benzo and opiate slide. So this is in when they look at associations between or what's associated with overdose deaths and overdose events in opiates, benzos double that risk. So there's a big push to get people off benzos, particularly if they're on opiates, and that's why. And so for people who just don't know, so psychiatrists, don't typically prescribe opiates, but we do prescribe benzos and stimulants. Those are our main controlled substances. And now we have to run a MAPS report. So people are familiar with MAPS reports. So it's the automated. So we have to do that now before prescribing. I think it's anything more than like a 7-day supply. So so that should be something that is happening before any of these prescriptions go out for the first time. And you can only do 30-day supply at a time of controlled substances. And you also can't. You have to have seen the person that patient in person. You shouldn't be prescribing a controlled substance to someone that the prescriber has not met in person. So you also, the other things to do, consider getting your own drug screen to make sure they're not using other substances. And then contract can be helpful just to make it really clear to the person, like, we treat this seriously. There's boundaries and expectations for this. And that means you can't lose your medications, you can't get early refills, you only see one doctor at a time, you attend all your appointments, and you make it kind of very clear up front. Okay, so what about, the question came, well, what about the people that only want a benzo for their anxiety? What are your alternatives? Obviously the SSRIs, are good for anxiety, so you want to have those probably as your base. And then here are some other options you can use with an SSRI. So buspirone actually works. It works kind of like an SSRI in the sense that it takes weeks to get to work. It doesn't work right away, but it's not. It's kind of like an SSRI, except for it's not good for depression. It's only indicated for generalized anxiety disorder, and it has a lot of GI side effects. You have to kind of build up the dose over time, so it's not a great option. Let's just be honest. So, but it can be used. Hydroxyzine, I see in my local area at the VA, it seems to be very popular now. It wasn't 10 years ago, but now it seems like everyone's getting hydroxyzine for their PRN anxiety medication because it's an antihistamine, it's not a benzo, so there's no physical dependence that develops over time. It works right away. So for your very anxious patients that really need a PRN, this could be used. I don't tend to do that a whole lot myself, but it can be. The whole thing with PRNs is that it's behaviorally reinforcing, so people tend to reach for a medication rather than a coping strategy. So I tend to avoid kind of going down that road. Gabapentin I actually like quite a bit. So gabapentin is not actually FDA approved in the U.S. for anxiety, although there's some European, I think, trials or approvals there. But what I like, so gabapentin is really indicated for, most often used for neuropathic pain, but it has anti-anxiety effects, and it actually is used in alcohol withdrawal syndrome. So as an alternative to benzo for people that are going through withdrawal, if they're not at risk for like a seizure or DTs, you can use gabapentin that can help them through the anxiety of going through alcohol withdrawal. And so if you have people that have had alcohol use problems in the past, their anxiety seems to be this sort of chronic restlessness thing that they've sort of self-medicated with in the past with alcohol. That's where I really feel like gabapentin can play a role and kind of help with their sort of daily kind of anxiety. Prazosin I put on here. It's not truly an anti-anxiety medication, so it probably shouldn't be on this slide, but it's used in PTSD. So you'll see this most commonly in people with PTSD, and it's used to help with nightmares primarily. There's a bunch of trials that came out. It's been pretty commonly used in the VA, but there's more recent evidence that has questioned its effectiveness. So right now we're in a little bit of a little bit of a murky area in terms of how effective it really is. But if you see that, that's where you're going to see it, usually PTSD and nightmares. Yeah?
It seemed like not infrequently I would see described as a first-line agent. Is that true? Or is it more of a second-line? Or is it more of a second-line? Or is it more of a first-line? Or is it more of a second-line? Yeah, is there evidence for it as a first-line agent?
For anxiety?
Yeah.
Just generalized anxiety?
Generalized anxiety.
I mean, so I guess it would be, if someone just had generalized anxiety disorder, first of all, in my experience, it's kind of rare that it's pure that without depression. But if they did, it would be fine, but I don't really see the advantage of it over an SSRI. It's fine to do, but I would still use an SSRI first.
Are there downsides?
To buspirone?
First and by
No, I think the downside for me is that so my experience, it tends to have a little bit more side effects. The gastrointestinal symptoms be a little bit more prominent. You kind of have to work your way up over time to an effective dose. So no, there's not really major downsides. I think it's fine. I don't tend to see that a whole lot. Usually people have depression as well. All right. So here, the second generation antipsychotics. There are a lot of these now. They seem to be multiplying, more and more all the time. But I highlighted the most common ones I think people will see, particularly in a primary care area. So Abilify and Seroquel or aripiprazole and quetiapine. And so these, were originally, they're called antipsychotics because they're mainly, primarily indicated for schizophrenia, psychotic disorders. They're also effective for bipolar disorder, so they're essentially mood stabilizers. And they're also effective, at least aripiprazole and quetiapine, for unipolar depression when used in combination with an SSRI. So So when I tend to think about these, so everyone practices different. I tend to not use these first or second, usually because of the side effect burden. So, and I put that down. So they have a lot of weight gain, diabetes are the big ones. So there's even an FDA warning that goes along with these medications saying these can cause severe, changes in your blood sugar. And so you really have to be careful with that. And so if anyone has any kind of weight gain or diabetes type issues, this is going to make that worse. Like cholesterol, this whole metabolic syndrome. They still have the potential to cause the same long-term side effects as the older antipsychotics, which is these like acute dystonias, but also the tardive dyskinesia, which is involuntary movements like your mouth, lip smacking, tremor, that kind of stuff. So long term, they have that problem as well, although it's less of an issue than the older ones. But so mainly because of this host, all of this, putting all this together, I tend to not jump in with the antipsychotics in the kind of first, second, even maybe third round. The time what I would be if there's a flavor of bipolar disorder. So if someone has, maybe they had a questionable manic episode in the past, maybe they have a strong family history of bipolar disorder, you're not really sure, you're a little worried, like, do I really want to start an antidepressant in this person and risk making their bipolar disorder worse? That's when these come in because you're basically hedging your bets. Like if they have bipolar disorder, you're good. You're covered. You got the antipsychotic on board. If they have unipolar depression, you're still okay because these are effective for that as well. So in that case, you might want to combine it with an SSRI. Then it gets to like, well, what do you start first? Do you start both at the same time? Do you do the antipsychotic first? That's something your psychiatrist can help you with. But that is a case where these might move up in the list and start thinking of this earlier. No. Yes. So I'll say that. So clozapine would not be typically prescribed by primary care. So the interesting thing about clozapine actually is thought to be more effective than the other ones, but is pretty much only used in schizophrenia, some cases maybe by severe bipolar disorder. The risk is that it has a risk of neutropenia, which is like a loss of your white blood cells. So there's all sorts of extra monitoring. You have to have like weekly blood draws. for a period of time. I think later on they can be spaced out further. So you almost need a special clinic to do that. So it is considered a second generation antipsychotic, but you would probably never see a primary care doctor prescribing it. The mood stabilizers. So these medications are pretty much, for the most part, you're only going to see in bipolar disorder, or it's like schizoaffective disorder. So lithium, valproate or Depakote, lamotrigine, carbamazepine. So the thing with these is they all have, kind of different, but in a large part, but serious potential side effects or risks of using them. So I think in a lot of cases, particularly in primary care, you might see, I would expect you to see the antipsychotics actually to get used before these in a lot of cases. If someone has like true blue bipolar 1 disorder, then they're on the inpatient unit after a severe manic episode, then probably lithium might be your go-to. But in other cases, you might see that those antipsychotics come in because of the problems they have at the bottom of this slide. So these are, in some ways, these could be worse than the antipsychotic problems. It's a little bit debatable. But so lithium, the big thing is it can affect your kidneys. It can cause kidney impairment over the long run. So, that's obviously a major concern. Lithium is also highly toxic in overdose, and you have to monitor the blood levels of lithium to make sure you're not getting to a toxic dose. And you don't have much of you have a very narrow window. So you can go from like therapeutic to toxic very quickly. And so that's a big problem with lithium. It takes a lot of extra management. Valproate or Depakote can cause liver failure. Has lots of side effects. You can lose your hair. You can gain a lot of weight. There's lots of side effects with that. Lamotrigine is actually generally not a lot of side effects. It's actually generally well tolerated. The only issue with that is that you can't go up to a therapeutic dose right away because you can cause a specific type of rash. That's a severe, very severe rash. So that's the issue with that one. Carbamazepine cause anemia. So these are the mood stabilizers, and then there's also birth defects. So with the lithium and the Depakote in particular. So in pregnancy, that's obviously a major concern. So those are those. Stimulants, I'll just touch on quickly. You basically have your Ritalins and then your Adderalls. They work very similarly. In the brain, their mechanism is pretty similar. So they're kind of almost, I think of them in terms of like side effects and mechanisms kind of interchangeably. The thing with stimulants, so obviously these are used for ADHD. They are actually generally safe to use. They don't have a lot of side effects. So it is a bit of a dilemma because on the one hand, they can be abused. They can be diverted. People can use them as party drugs. People can use them as just study aids to cram for a test. So they can kind of be misused. But generally, they don't cause serious problems. I mean, in most cases, sure, people could get addicted to them, but generally that's not the case. It's not like they're not as bad as opiates, I guess I would say in that case. So it's a bit of a cost-benefit issue there. You do want to check, like I had talked earlier, about a substance abuse history, do the MAPS report, do the contracts, urine drug screens, guidelines, all of that. These come in like short-acting and long-acting, and there's issues around that, but we don't need to go into that right now. I just touch on these medications because I think this is becoming more prominent now with the opiate stuff. But so there's treatments for opiate addiction, opiate use disorders, so methadone and Suboxone. So basically, those are what we call opiate agonist therapy, which is basically replacing their opiate. If it's heroin or some kind of opiate pain medication that they're addicted to, then you replace it with methadone or Suboxone, which it kind of reduces the craving and are generally safer medications. Narcan is that reversal agent that can block opiate receptors and reverse an overdose. So you probably won't see these a lot in your clinic area, but I just kind of bring them up. You will see probably the last ones, actually, the Chantix, Wellbutrin, and nicotine replacement therapy for nicotine use disorders. That would be in your primary care area. And so some people might get the referrals for, can we start Chantix in this person because there's some reports of sort of neuropsychiatric side effects. People can have like an increase in suicide risk with that. So usually in that case, I tend to not recommend they use Chantix if there's any prior risk, like a suicide risk. And I'd say, let's try to think of something else. Yes, was there a number? Okay, so let me get through this. So I think most of this is review. So we know antidepressants they need to be taken daily, not PRN. They take 2 to 4 weeks to see a benefit, so they don't work right away. So these are things you want to warn all your patients about before you start the medication. Before I go, anything else on these other non-antidepressant medications, the other major med classes? Okay. So, so the 2 to 4 weeks thing, some people will say that they notice a benefit right away, and I don't tell them that's wrong. I just say, I say, okay, and honestly, the 2 to 4 weeks is from trial data on average. That's where you see separation from placebo. So it's still, some people could see a real effect, I think, in a few days. It's possible. That's that. So, okay, so here I'm going to run through these common questions that we get. So, are antidepressants just a placebo? So, no, they're not just a placebo. Is there a placebo component? Yes. So, and this is one of the things that, is tricky when working with patients, because there is a strong placebo effect, and you don't necessarily want to take that away from them, but you want to be honest as well. So, I don't know. So, how you work that out, I kind of leave to all of you. But basically, yes, it's not just placebo. There's very consistent trial data that shows that antidepressants work compared to placebo. There's some, controversy about how well they work, and do they only work for more severely depressed patients. I am not convinced by that, so I generally feel that as long as they're depressed, their PHQ-9 is about 10 or higher, then I think that they are reasonably effective and worth trying. Do antidepressants cause suicide? So that comes up occasionally. The FDA has looked at this closely. There's a black box type warning on them, or they've issued their guidance, and that the risk seems to change by age. So if you're 24 years or younger, there is some suggestion that antidepressants increase your risk of suicidal thoughts or behaviors, not suicide death. That there's not data to show that, but suicide thoughts and behaviors, and so that is a concern, and that should be, if you're treating younger folks with antidepressants, you want to make sure that they're aware of that, you're aware of that there's some monitoring in place, but after that, there's really no evidence suggests that they increase the risk of suicide. And even as you get older, it seems to be that they're more protective for suicide. So this data, there's a lot of controversy around this in terms of what data we're using to determine these effects. Other studies, like large epidemiologic studies, suggest that they're associated with fewer suicides. The problem is when you do a study where you say, I'm going to look at this person and see they started an antidepressant, and then we're going to look at their suicide risk right after that. Well, they're depressed. The reason they're getting antidepressants is because they're really depressed right now. So those studies are problematic. You really need these controlled trial studies, which is what the FDA looked at. Are they addictive? No. They're not addictive. They're not abused. People aren't, right? Robbing houses to get more antidepressant medications, that kind of thing, right? So, but it's tricky because they do have this discontinuation syndrome, which sounds like it's like withdrawal, but you're trying to call it something else, which is just kind of true. But so you have to kind of dance around that. Well, they're not addictive, but there is this discontinuation syndrome, which means that if you stop them, you could feel unpleasant, you could have these like zaps or side effects, but it's not addictive. It's not like you're gonna, right? It's not gonna, you can talk about the difference between addiction and that. This is the most common one, right? I know my cousin took an antidepressant and they were like a zombie. We always get that. It's going to turn me into a zombie. So I basically tell people, like, I don't want you to be a zombie either. Trust me, I don't want you to be a zombie. And I just say, what I usually tell people is that they don't brainwash you. If you're going to know how it's affecting you, and so if you don't like it, we stop it. You will know. You will be able to know and tell me, but you're not going to be brainwashed by these medications. Some people, and then sometimes I'll say, do you really know everything that person's taking? Because they could be on other things besides just the medication we're talking about. Yeah.
I more often have patients tell me
Yes.
would we talk to them about trying a different, would that be an option for them?
Yeah, that's what I would do. Okay. Yeah. Oh, if your patient says, I felt like a zombie, which I don't, I've gotten a few times. I don't get as much, maybe other people do. But then yes, I would just stop it and try another SSRI. Yeah. I'm going to not do that. Okay, am I going to be on this medication forever? So this kind of gets to how long do we treat people for. So the standard recommendation is if this is their first episode of depression and anxiety, then at least 6 months, generally 6 months to a year is kind of how I frame it. And then if everything is good, then we could try taking you off. If you've had multiple episodes over your lifetime, these medications are probably, they're going to prevent future episodes, decrease your risk of future episodes even after you get better. So in that case, I would recommend, at least considering, obviously it's up to the patient and what they want, but my recommendation would be to just stay on them indefinitely. And I usually say people do that all the time, stay on these medications. There's really not any long-term side effects other than like small amounts of weight gain that over time that we don't know that it causes any problems, and people do it all the time. So, and then if it's really important and you want to push a little further, you can say, I think about it like diabetes or blood pressure or cholesterol, like people stay on those medications. Can be thought in the same way. I don't get people asking me this all the time, but it's the way to talk about adherence strategies. So, and we can kind of skip through it. There's just basic behavioral stuff. I'm sure you guys have thought through this with your patients. Okay, pregnancy. We're almost out of time. Okay, so let me see what I have left. Older adults, medical morbidity, conclusion. Okay, good. We're almost there. So basically, the pregnancy thing is it's risk-benefit, no complete contraindications for antidepressants. There's some risks of basically in the neonatal period that they might be more likely to actually need an NICU stay. There's this pulmonary hypertension thing that can cause, but the SRS generally do not cause birth defects, but they can complicate the perinatal period. And so that's kind of the main thing. Usually that's a careful conversation weighing the risks and benefits, but definitely people stay on antidepressants throughout pregnancy, and most of the time it's not an issue. The mood stabilizers I talked about, like lithium and Depakote, Tegretol, those are the ones where it's even more serious conversation. Again, it's still possible. So it's, increasing your risk of like a heart defect from like 2% to 3%. It's like you really have to think about stuff like that. Older adults. So basically, the motto here is start low, go slow, but don't stop. That means in your older adults, you might have the normal starting dose, and you just go from there. So, and that's the same thing as someone who has like liver impairment or kidney impairment. You just start lower dose, and you just go slower. You don't want to do anything with anticholinergic properties, benzos, TCAs. That's also things like the hydroxyzine or Benadryl, those types of medications. I talked about all that. Talked about seizures. Talked about that. Okay, so I think that's it. All right, yes.
I just was recently reviewing a study, a meta-analysis by McMaster about actually SSRIs demonstrating increased mortality.
I have not seen that, so I need to take a look at that to comment on that.
In non-cardiovascular patients, it showed protective factors in cardiovascular patients, but not in the general population. It actually showed statistically significant increases across lots of, like, a big meta-analysis.
Yeah. Oh, a meta-analysis. Yeah. I'd have to look at that. I mean, obviously, so my first question would be: is that on those observational studies that you're looking at? Because if you take someone that's depressed and you look at who's on antidepressant and who's not on an antidepressant, then the people on antidepressants, the people like me, like have more severe depression, typically. So that'd be confounded by the severity of their depression, and we know depression is associated with mortality and cardiovascular risk. So I would need to scrutinize that a little more closely before I would blame the antidepressants themselves for that. But you could forward that to me. I'd be really interested to look at it. Yeah.
Do you feel that these medicines are
No, I don't. Question was, do I feel these medications are overprescribed? The antidepressants, SSRIs.
Yeah.
So I don't, but I will say, has anyone read the Lost Connections book that came out? You might be able to look it up, but it's a reporter that wrote a whole book about arguing that we have depression all wrong, that we're over-focused on the medical model and medications, and we are totally. If people need to leave, by the way, that's fine. But so I don't know. I disagree. I mean, I think I don't think they're overprescribed because they're generally safe, and I really am upfront with patients. Like, here's the data, here's the information. It's up to you what you think. Like, there's certainly other options. You can do therapy, you can do exercise. There's so many ways to treat depression. This is one. And so I let people make that decision. I'm not pushing medications on people. It's sort of like it's an option, and people choose that option. So I guess I take a little bit of issue when people sort of frame it as psychiatrists pushing medications on people. It's people coming to us, and wanting a medication we offer to them. So anyway, that's kind of my feeling. But I do think this issue with the placebo effect and how much it is placebo versus active ingredient is an ethically challenging one, in terms of like, if what we're giving is mainly placebo, what does that mean? I don't know.
You mentioned the two-study rule, so
Yeah.
shown to be effective
Right.
twice.
Right.
They could have had 100 trials,
Right.
and if 2 of them are now effective, but
Yeah.
100 weren't, then that.
Yeah.
would be ethically
That's changed now, in my understanding. They have to pre-register their trials. But I don't know if that they can pre-register 5 and then fail 5, and then still have 2.
good ratio.
Yeah. No, that's a good point, though. That's one of the major criticisms,
Right.
that they just need to have a couple hits and then they're good. Yeah. Yes.
The question that patients most ask me is this changing my brain chemistry? Am I going to change my brain chemistry so that now I have to be on this medication? I don't want to start it because now I'll have to take it the rest of my life.
Right. I would say no to that.
I mean,
It does change your brain chemistry.
Yeah.
I mean, that's how it works, right? I mean, that's the only way it would work. And in some ways, it could permanently change their brain chemistry in the sense that, I mean, it alters the course of their life. So that's your brain, right? So, but no, you don't. I would say you don't have to. That doesn't mean you have to stay on this the rest of your life. People are able to come off of these, without problems. I guess the thing is that if they come off of it and then their depression gets worse, it's not like the antidepressant caused that situation. It's the antidepressant that's keeping that situation from occurring. So it's a way of framing it, I guess.
Yeah.
All right. Well, thanks everybody. And I can answer questions later after. Thanks.